So bienvenue, welcome everyone to the webinar Contingent, Universality and the Making of Global Guidelines for Mental Health. For those who don't know me, my name is Monica Ruiz-Casares. I'm an associate professor of psychiatry at McGill University, and I coordinate the Global Mental Health Research Seminar in the Faculty of Medicine and Health Sciences. I will be moderating the webinar today. This webinar expands on the training that we offer in the McGill Summer Program in Social and Cultural Psychiatry and aims to raise awareness of mental health disparities around the world, exchange social, cultural, and critical research in global mental health, and build bridges across sectors, languages, and geographical locations. We're very happy that you're all with us here today. A couple of housekeeping points before I introduce our speaker. The session is being recorded, and we will post it in the McGill Global Mental Health Program website, together with some readings that our speaker has selected. And the session will last 90 minutes, during which we will first have the presentation by Dr. Mills, and then we will have a question and answer period, a discussion period. So take note of your questions. You can send them along through the chat, or you can keep them and you'll be able to unmute yourself at the end and ask the question directly. I just look forward to having very good discussion. So, but for the time being, please make sure you're muted. So let me introduce our speaker. Dr. China Mills is a senior lecturer of public health in the School of Health Sciences at City, University of London. She studies the policies and practices of global mental health and the politics of suicides linked to welfare reform, border imperialism, and corporate practices. Her book, Decolonizing Global Mental Health, is probably well known by everybody here, but it's certainly worth a read to be shaken with questions about the global aspect of global mental health, what counts as evidence, and global mental health policies as forms of colonial discourse. It's late in the day in London, and probably where some of our participants are as well. And we really appreciate your flexibility joining us at this time. And thank you to China for juggling getting the baby asleep and testing the technology and just getting centered to be with us for the next hour and a half. So we're very excited to have you with us today and look forward to your presentation. The floor is yours, China.
Thank you so much, Monica, and just thank you very much for inviting me, and thank you all for turning up from all different parts of the world to listen to me. That's a real honour, and thanks so much to Sakiko for supporting me in getting this to happen and in being super organised and incredibly helpful. I really appreciate that. So a key assumption in my own work is that all knowledge is situated and comes out of a context. And so I'm going to situate myself and my ways of knowing a little bit first, just as a way to begin. So this talk today is about how knowledge that claims particularly to be universal or global is always negotiated, can be contested, contingent, etc. And so just situating my own work is important, given that that's my approach to thinking about global mental health. So a good place to start, I think, and I'll talk a bit more about this in the talk, is my title, for which I think I owe a really big debt to the brilliant Dorte Bem, who I know is very well known, so lots of you at McGill, and her work on contingent universals in global mental health, which I will talk about very soon, but I would massively recommend for anyone who hasn't come across it. And I'll also talk you through some of the concepts that I'm thinking with as I do the talk today. So just to tell you a little bit about me, and the reason I'm looking over here is I've got two different screens going here, so I'll try and remember to click on the right one. So I'm a white cis woman. I'm based in the UK, in London. As Monica said, I've got a little baby in the other room in my tiny apartment, who was born during the UK's first lockdown. I've just put him to bed because it's 8:30 p.m. here in London. That baby doesn't like to sleep, so he may well join us at some point in this presentation, and you'll most certainly hear him at some point, so I'm just warning you. So to give you a little bit about how I came across and started working within global mental health, I was actually doing I was in India doing my PhD research when I first heard the words global mental health put together in that way. It's probably around 2008, 2009. And it was significant to me because I've grown up with family members who hear voices and who have schizophrenia diagnoses. And our experiences and their experiences had been very medicalised. My family members took medication. They were forcibly taken to hospital at various times. And we and they had never come across kind of other different ways of understanding, I suppose, than psychiatric explanations at that time when I was a child. And so it was in 2007 when I went to University of Manchester to do a psychology degree that I first came across the Hearing Voices Network, which was then just an office in an old building in what has now become a very gentrified part of Manchester, but certainly wasn't at the time. And I just found it mind-blowing to hear people talking about just very different ways of understanding and talking about hearing voices and their experiences that weren't so located in a kind of medical or psychiatric model. And it was that experience that made me want to do a PhD in the first place. And then I was lucky enough to be able to do quite a lot of that field work with the Bapu Trust in Pune in India, who are just an amazing organisation run alongside and with folks who have lived experience of mental health problems, diagnoses, the psychiatric system in India. And even 10 years ago, I should say, it was a lot easier to get funding to do a PhD than it is now. I feel it's important to acknowledge these things. And so after finishing my PhD, while I was desperately applying for an academic job, I turned my thesis into a book, which was called Decolonising Global Mental Health. And since then, I've continued to do research in this area in various different ways. And so doing this work for a while has given me the chance to meet a lot of very different folks connected to global mental health. So some people who, I suppose, throughout this talk, I will call advocates or proponents of global mental health, though these terms are all kind of loose and there's lots of fluctuation and movement for these different people. And I've also met some folks who are very, very critical of global mental health and lots of people who sort of occupy a space in between. And I've been lucky enough, just from being invited to speak at various things, going to various events, conferences, etc., to get to hang around with some of the advocates of global mental health and to hear some of the critiques of global mental health that come from those advocates. So I suppose the kind of internal critiques and some of the sort of backstage talk, I guess, that happens around global mental health. And I feel I've learned a lot from that. I think it has not made me less critical, perhaps, but I would hope that it's made me a little bit more nuanced in the way that I think about it and in that critique. So there's been a lot of learning for me in doing that. And one example is what I'm going to talk about today around the first bit of global mental health, the global bit, okay? And so the construction of mental health as a global issue that's significant to global health, international development, etc., has really been central within global mental health messaging. So, for example, the Landsat Commission on Global Mental Health and Sustainable Development from 2018 states that mental health is a global public good, a universal human attribute, and an indivisible component of overall health. Okay, and that's a quote from the report with Vikram Patel being the lead author. And similarly, in their textbook, Global Mental Health Principles and Practice, some of the key kind of movers and shakers, if you like, of global mental health, so Alex Cohen, Vikram Patel, Harry Minus and Martin Prince, talk about the field of global mental health as, to quote them, arriving at something of a consensus. So they say, although there is ample evidence of differences in the expression of and responses to mental disorders, it's generally agreed that these health conditions affect people in all cultures and societies. So in contrast to this, critiques of global mental health, including my own, have also tended to focus on the questionable global bit of global mental health. So some of the quite well-known critiques around the globality or universality of mental health come from people like Derek Summerfield, who says that to say global mental health is an oxymoron and a form of medical imperialism. Or more recently, Helmariam and Pathare saying that it's time to reconsider whether work concerning global mental health is truly a global reflection. So, for example, in the works of high-income country scholars doing work in low and middle-income country contexts. So it's no wonder then, given this situation, that Sarah Cooper has written about global mental health as being a hostile intellectual climate, where people are locked into constrictive terms of competing perspectives that limit cross-fertilization of ideas. So, for example, being locked into this debate of is mental health global or not, or universal or not. And I've been locked into those debates many times, and I'll be honest, I do still feel that they're important, and I know a lot of people do still feel they're important, because it's like one of the main, kind of the crux of global mental health in some ways, right? But the debates also often close things down, I think, in ways that aren't always that helpful, or certainly not very enabling of conversations across very different perspectives. And so, in their brilliant 2014 paper on global mental health and its discontents, Dorothy Bem and Nicole de Souza talk about how both critics and advocates of global mental health at times rely on an imagined incommensurable local global binary. So it obscures, Bem and de Souza say, emergent spaces, concepts, and fields of inquiry between and beyond divides. Okay. And in fact, in my own encounters, as I said, with a lot of the advocates or proponents of global mental health, I've realised that essentialised categories of critics versus advocates doesn't quite hold. And in the work I'll talk about today, we'll see that actually some advocates of global mental health share a lot of the same concerns of those who've written social scientific critiques of global mental health, particularly around the dominance of medicalisation or of pharmaceuticals within global mental health. And so, differently from debating whether or not mental health is global, what I'm hoping we could talk about today is thinking about the conditions of possibility that produce and legitimate mental health as global. So I want to focus on what the framing of mental health as global does and some of the ways that it's achieved. So before I tell you about the research methods and findings, I need to introduce you to the focus of the research. And so I want to talk quickly to you about the World Health Organization's Mental Health Gap Action Programme guidelines and intervention guide, because that's like my way into some of these discussions, and that's the thing that I've been doing research on. So before I tell you about the methods, I'll just introduce you to this World Health Organization MH-GAP intervention guide. Okay, so generally within global mental health, the World Health Organization kind of discourse around this, we see quite oft-cited statistics around how much of the global workforce works in mental health, that being only 1%, but also a very often cited statistic, and that is that 45% of the world's population live in a country with less than one psychiatrist for 100,000 people. Okay. Sorry. And so a key solution put forward, and let's just bear in mind that the way of presenting a problem obviously then affects the way that a solution can be thought about or presented. So if we think about the problem is presented in this way, as there being very few psychiatrists globally, or very few people in the mental health workforce more broadly, one of the solutions that's then put forward by the global mental health community is the idea of task sharing or shifting, which I'm sure you're all familiar with, but is the delivery of services by people who are not themselves mental health professionals, generally across routine care settings. That's a WHO definition. And so the Mental Health Gap Action Programme, the MH-GAP, describes itself as aiming to scale up services for mental, neurological and substance use disorders with a focus on low and middle income countries, but not only in those countries necessarily. And the key product of MH-GAP is the MH-GAP Intervention Guide, which is a simple tool defined by the WHO as helping to detect, diagnose and manage the most common mental, neurological and substance use disorders. Okay. And so the WHO refer to the MH-GAP Intervention Guide as an evidence-based technical tool aimed at supporting non-specialised healthcare providers to redistribute clinical tasks previously reserved for mental health specialists. And it's also worth pointing out that the intervention guide is also available as a smartphone app that you can just download from Google Play or other places and just use yourself on your smartphone if you've got one. And so these guidelines and the MH-GAP intervention guide are really significant. So the guidelines have been used in over 100 countries. They've been translated into many different languages. And they are often described as being something, so for example, Vikram Patel, a key figure in global mental health, describes the guidelines saying they should become the standard approach for all countries. And Tarun Dua at the WHO says that MHGAP has provided a definitive platform to define what should be scaled up. So we're seeing that there's a kind of real thing of standardization here, that these guidelines should be being used and enabling scaling up globally. Okay. And so I thought it's just worth saying that my understanding then of the MH-GAP intervention guide is multiple, and that in the ways that it's practiced and done, it's talked about and used in very different contexts in different ways. And the alignments and contrasts between these different ways of doing, I think, are analytically important. So, for example, one of the photos here is a picture of the MH-GAP annual forum that happens at the WHO. Below that is an example of some psychological first aid work from within the MH-GAP intervention guide being used in the field, if you like. And above that is a picture of someone using the MH-GAP smartphone app. And so even though the guidelines and the intervention guide are a specific object, they're obviously being talked about and done and used in very different ways in these three and multiple other examples. And that's perhaps worth just being clearer. And so from 2017 to 2019, I led a couple of projects, both funded by the British Academy, that allowed me to look at numerous other things, but also to focus in on MH-GAP intervention guide and explore the kind of social life, if you like, of the MH-GAP. And just to say, I was assisted in that by two fantastic research assistants, Kimberly Lequat, who's based at the Bapu Trust in Pune in India, and Dr. Eva Hilberg, who's based at University of Sheffield now in the UK. And so the methodological approach here was, I suppose, tried to be a little bit different from some of the literature on MH-GAP, which tends to focus on implementation in different contexts. But less focus has been on the actual context from which the MH-GAP itself was produced. So it's kind of shifting the other way and looking at where it's coming from rather than only the ways that it's being used or implemented. And so this work, this research that I was doing, conceives of global mental health tools more broadly, and including MH-GAP, as being culturally constituted objects. And so it's important for us to look at their conditions of production, as well as the ways that they get used and their consequences of those uses. So I'm interested then with Donna Haraway in those knowledge power processes that inscribe and materialize mental health in specific ways, and even more specifically in the ways that it's inscribed and materialized as being global. And so this I kind of think of as being the social life, I suppose, of MH-GAP and of global mental health tools more broadly. And so key to the development of this research then has been my reading of the rich interdisciplinary scholarship from medical sociology and science and technology studies, as well as anthropologies of psychiatry and of technologies, and specifically empirical research into standardization, classification, and development of medical protocols and guidelines. Some of the books I found really helpful are just on this slide here. So they include things like Stefan Timmerman and Mark Berg's work, and Sally Engel-Merry, and Marie Moll, so various different people who look at those processes of standardization. And so I'm arguing here that this literature on standardization is really useful for global mental health because it shows us that global expansion and standardization are messy processes, and that universality and universal guidelines, say, are always crafted, they're contingent, they're negotiated, and they're often contested. And so in analysing my data for the ways universality is negotiated and contingent in relation to mental health, as I said before, I found the work of Dorte Bem really helpful, and I just want to go into that in a tiny bit more detail. So Bem argues that the evaluation framework theory of change used within global mental health produces contingent universals, And so these she defines as concepts that are true and measurable until they stop working in the field, or until the parameters of what works shift to a new iteration. And in her brilliant 2018 PhD thesis, which Dorte shared with me very recently, she argues that we need to situate our analysis of contingent universals within, to quote Dorte Bem, a broader lineage of how the universal has been crafted, mobilised and critiqued. And hence the title of my talk, as I said earlier, this idea of contingent universality. And that's so that wider understanding that universality is always to some extent contingent, as well as drawing on Dorte's work on contingent universals. So to tell you a bit about the actual research I'm going to talk about, between July to December 2018, I carried out 19 interviews. Well, I didn't carry out all of them, but I carried out 9 interviews with members of the original MHGAP Intervention Guide Guideline Development Group. And there were originally 21 members of that, so with 9 of the 21. And then Kimberly Lacroix, who I mentioned before, working at Bapu Trust, carried out interviews with some of the implementers, if you like, of MHGAP, so people with global experience of carrying out and implementing MHGAP, but especially in India and West Africa. And this presentation today focuses on the former, so I'm going to talk to you about some of the things that the makers of MHGAP, the Guideline Development Group, talked about with me in the interviews. And so I was interested then in the interview protocol. I was asking people about what Bowker and Starr refer to as behind the scenes boring background processes. So I was interested in thinking about the kind of banal decisions that happen in the making of these sorts of global tools, okay? But the things that are sometimes left out of, I guess, kind of more official histories. And so there was a focus then in my research on these banal, mundane practices. How are decisions made? Who asked who to be involved? How did documentation take place? And I think those processes are key to making global mental health global. But that banality doesn't necessarily make for the most riveting of talks. So for this session, I've been a little bit choosy about what I'll focus on to try and make it slightly more interesting and left out some details, but I welcome your questions about the more mundane processes if you're interested. So one area of discussion in the interviews was around the formation of the Guideline Development Group. So these are the people, the 21 people that came together to review evidence and put the guidelines essentially together. Okay. And talking to people about that process involved them remembering back to 2008 when it was made. And so the fluid nature of memory doesn't always lend itself, of course, to the most accurate, I suppose, of recollections. Yet what people remember about developing the guidelines is itself something that's really interesting. So because of the always kind of emergent nature, I suppose, of doing these things. So for example, if participants remember no tensions or they don't remember any disagreements in the process, then this might suggest implicit assumptions around consensus regarding mental health in that group of people. So this talk then focuses on how the design of MHGAP and its intervention guide is narrated by those who designed and use it, and how these ways of talking about it actually do mental health as global, but in multiple ways. And so just to give you a brief outline of the different kinds of memories of the process that people had, there was generally a focus, I would say, on consensus, but there was quite different memories about the whole process. So people perceived, for example, they had very different ideas about the diversity within the 21 people that made up the group. Okay, so some saw it as being very international, including people who work in low and middle income countries and having a good kind of regional and gender balance. Others said that it was set up by a group of mates who wanted to change psychiatry, and it was a very congenial, collegial process. There were a lot of personal relationships and friendships. Another thought that it's quite a homogenous group of people. They were all professionals who work in the field, but there was no representation from mental health service users. And that this particular person felt that there wasn't any representation from people who were critical. Others may have felt differently about that. It's just worth me mentioning here that of the 21 people who made up the Guideline Development Group, there were no people who openly identify as service users or psychiatric survivors. I obviously can't speak to if they have lived experience or not. Only 5 of the 21 people are female, and 18 of the 21 are psychiatrists or professors of psychiatry, with the remaining 3 of the 21 being 2 psychologists and 1 neurologist. So there is a strong kind of professional background in psychiatry, I suppose, there. So that's quite interesting, because of course, perhaps to me that looks like they're quite a homogenous group, but obviously for some of the people in that group that was still experienced as quite diverse, because perhaps of coming from quite different perspectives even within psychiatry potentially. And so the findings that I want to talk to you today centre on some of the strategies used within the development of the MHGAP intervention guide to achieve universality. And we'll see a number of strategies at play, and I'll summarise those at the end of this talk. So one thing that I thought was really interesting about what people said was that MHGAP intervention guide, the guidelines, I'll just call them, were talked about as being key in changing narratives and discourses about the cultural relativity of diagnoses. Okay. So cultural relativity was seen to be destructive and nihilistic, mainly because it was associated with inaction or lack of action. So the guidelines were seen to make an important contribution to a perceived, to quote a participant, paralysis in the mental health sector. So just to summarise the quotes that are on the screen, one interviewee said the conversations around mental health had been really destructive. The idea that social and cultural practices are so important that you couldn't do anything anywhere was a prevailing nihilistic view in ministries of health and clinics. And MHGAP has changed that discourse. So it allows you to have common rules across different contexts, they said. Another person said before this was paralysis in the mental health sector. MHGAP helped move mental health into an equal position with physical health. So constructing the significance of the guidelines also involved invoking a time before MHGAP, where healthcare systems are described as doing nothing, and meaning that the greatest contribution of the intervention guide was to make systems feel there was something that they could do. So here we can see then that universality is seen in this kind of way of talking to equal action and pragmatism, and it's positioned as being opposite to, and I think preferable to, from the interviewees, cultural relativism, which is seen to equal nihilism or paralysis or inaction. So here, in some ways, MHGAP is framed as a solution to the epistemological issue of universality of mental health conditions or mental disorder, in quotes, and as a way to move beyond presumed nihilism to initiate action. So the assumption is written into MHGAP in the guidelines then that symptoms are universal in nature. Yet some of the participants felt that that universality came at the cost of a more contextual approach. So one participant said that there's a very strong desire to make MHGAP and other psychological and therapy manuals as rigorous and as universal as Newton's laws of gravity. What they're trying to do is basically create universal things. And when you try to create universal things, then this cultural context becomes like footnotes. This reminded me quite a lot of Andrew Lakoff's research into diagnostic liquidity and the way that biomedical knowledge is materially and discursively forged via standardization. And Lakoff calls this process diagnostic liquidity. So the way that classificatory practices that produce mental health diagnoses attempt to produce it as coherent and stable or durable, or as entities with universal properties. Despite positioning the guidelines as a remedy to the nihilism of cultural relativism, those interviewed still held quite different understandings of the universality of different diagnoses and conditions, especially manifest in the idea that certain diagnoses and interventions are more universal than others. And so this just to stress is really interesting from a set of people who are obviously creating universal guidelines, still have very different ideas about which diagnoses and which interventions are universal or not. And so some people spoke, in fact, I didn't ask this as a question actually, nearly everybody brought this up themselves in the different interviews. I think all the guideline development group members talked about schizophrenia and psychosis as being more uniformly biological, to quote them, universal and transferable across cultures, than mood disorders, whose universality was described as contested and negotiable. So people saying, well, with depression, it's quite a mixed bag and different kinds of presentations of symptoms going on, whereas that wasn't felt to be the case with schizophrenia. And as with diagnoses, the interview data suggests that some interventions have achieved different levels of durability and universality, and are more liquid then, to think of Andrew Lakoff's term, than others. So the universality of pharmacological interventions was not imagined to extend to psychological interventions, such as cognitive behavioural therapy, which was described as not being universal or as being more cultural. So despite differing ideas about the universality of mental health emerging in the interviews for this research, participants themselves didn't recall any debates about universality as sites of tension in the making of MHGAP and the guidelines. So even though they have different ideas about disorders being differently universal or not, that wasn't remembered as being an area of discussion when the guidelines were actually being first iterated, first forged. And so perhaps because the production of the intervention guide and the guidelines was based on the assumption of its global use. So that could mean that that universality was foundational to the development of the guidelines. So differing opinions about that amongst the guideline development group members were potentially put on hold or bracketed out. And so the construction of the universality of the guidelines as enabling action links to discussions throughout the interviews, which were around recognising and voicing critique and complexity, but delaying that for a later time in favour of more immediate action to kind of act now. Okay. So throughout the interviews, the people I spoke to showed really nuanced and very complex understandings, some of which align with social scientific critique of global mental health. For example, they explained that the guidelines are still a fairly crude measure. The intervention guide is probably the best we can do for now. One participant said, I feel the decisions made were the best decisions that the group at the time could make for public gain. Another person said, any first version is not going to be perfect by a long way. And another said, there's a whole complexity to mental health that can't be captured in a 100-page guideline. This aligns with Dorothy Bem's findings in her thesis that I said I was just reading the other day, which was an ethnography of the theory of change knowledge practices in global mental health, where she says she would encounter distant echoes of critique sometimes, which, to quote Dorothy, seemed to have moved from the toolbox of the critic to those of the practitioner, end quote. And I could really relate to that. I could see a lot of these kind of the shifting of critiques in that way. And yet participants in my research acknowledgement of critique and complexity, as I said, was often accompanied by a kind of temporary prioritising of a pragmatic approach. So yes, of course it's more complex. Yes, we need to be critical, but we need to leave that for now, because what's important is that we act now, and it's a kind of the urgency of ending suffering, I suppose, being the way that people justify that. Linked to this was that participants' recall of tensions in the making of MHGAP tended to centre on quite technical issues of doing the guidelines, and was less around the epistemic infrastructure and epistemology of mental health's universality. So what I mean is it was more about how the guidelines are done than the assumptions that are actually written into the guidelines. So in participants' recollections of the guideline development process, consensus was much more significant than tension or disagreement. And one area of consensus in the guidelines, in the making of them, was around evidence. So in the interviews, evidence was a really key discussion point, and kind of divided roughly into two interrelated sub-themes, which I'll just talk briefly about each. One of those was the prioritisation of randomized evidence as the gold standard for the guidelines. And the other was the issue that the majority of evidence used for the guidelines actually comes from high-income country settings, and that was seen to be problematic. So I'll just talk about both briefly now. So as I said, the choice to use randomized evidence was an early area of consensus, and also I think part of the WHO's approach in developing guidelines to use this kind of evidence. But it's important in the way that it then achieves this form of either contingent universality or the way that universality is constructed in mental health, that randomized evidence plays a part in that. But those who wrote the guidelines were aware of the problems with that. They said we made a choice of giving priorities to systematic reviews, for example, but that the process being highly dependent on randomized evidence means that pharmacological interventions tend to get prioritized despite the intentions of the group members. And one interviewee explained that's because the drug companies have an interest in producing the clinical trials. And so as a consequence, many of the recommendations in the guidelines are for pharmacological treatments. This is something I'll return to in a minute. And so one participant felt the need to stress that actually we really do emphasise and stress the importance of psychological and psychosocial interventions before, for example, antidepressants in the guidelines. Yet despite the guidelines including a range of psychosocial interventions, the interviewees talked about the guidelines' potential as a tool for medicalisation. So one participant said, with people saying, actually, what you're implementing is more use of medicines with a risk of medicalising social problems. And that medicalisation seemed to result from randomised evidence, but also drug treatments having more traction in many local contexts. And so I found it helpful that one participant explained to me that when you have guidelines that present both psychosocial and social interventions as well as drug interventions, what de facto happens, what has happened, and that is actually that drug interventions are the ones that have the most traction. At the end of the day, it could be that the prescribing of medicines is the easiest way of doing something, and that is a systems level problem. So this suggests then that a kind of delayed complexity in favour of urgent action intersects with local health infrastructures to favour pharmacological treatments as being just the easiest way of at least doing something, despite inclusion of psychosocial interventions in the guidelines. That drug interventions then are attributed more traction might be because of the assumed universality of pharmacological interventions. So as one participant explained to me, because it's considered to be a universal fact that fluoxetine as a drug, as a molecule, works for depression in all populations, so what is there to adapt in that? And so a particular issue that was described as eliciting much discussion amongst the guideline development group was about the applicability of evidence from high-income countries to low and middle-income countries. So one participant summarised this as one of the major limitations of the whole process, and they mean the guideline development process, is that 80 or 90% of all the evidence upon which the recommendations were made come from high-income countries. And it was intended, and yet the guidelines are intended to be applied in the countries of which 85% of the world's population lives, which is low and middle income countries. And they said automatically there's a sort of discontinuity there. But they said as a group, we decided to see which of that evidence from high income country settings might well be usable in much less well-resourced parts of the world. From an early stage, we decided that we would not disregard low income, high income data for that reason. So that was a really early decision that was part of the guideline development group process, and one that had obviously really quite big impact in terms of how the guidelines then look and some of the assumptions written into them. So here the potential tension around the universality of mental health manifests then in a debate about around the applicability of evidence from high income countries for use in low and middle income countries. And as I said, it was resolved early on. So as one participant explained, the paralysis, to quote them, in the mental health sector that you see for the last 30 or 40 years has been largely around the idea that evidence generated in one context cannot be applied in any other contexts, end quote. So here the assumption that the context of knowledge and evidence production about mental health has an important impact on how this evidence is implemented and done. So it's often deemed to be a form of cultural relativism, which we talked about before, and that's seen to be a form of paralysis. Similarly, alongside a lack of evidence from low and middle income countries, a further issue raised by participants was that much of the evidence came from specialist provider settings, yet it was being applied in non-specialist provider settings. So the impact of initial design on adaptation and implementation was a key point of difference in understanding between the people that I spoke to, with some of them stating that the guidelines were always designed with the idea of country-level adaptation in mind, while others felt that the universal design of the guidelines and their underlying assumptions leave little to be adapted beyond a simple matter of replacement of terms. So one interviewee, a psychiatrist with experience in using MHGAP, explained to me, let us say in the British context, you will say John is very sad. In an Indian context, you will say Ram is very sad, and that's all that it is. There is very little scope for doing any contextualization. So others shared concerns that one of the limitations of MHGAP is that it's a very disorder-based construct. And the tricky thing with the way in which people present in primary healthcare settings is that they don't knock on the door and say, hello, I'm depressed. It's very messy, actually, in the real world of primary care clinics. These concerns raise the issue then that the design of global guidelines can sometimes be in tension with the messiness of the contexts in which they're practiced, negotiated, and given meaning. But also then here, messiness is being ascribed to local contexts of primary healthcare, but messiness is not being seen in the process of designing and constructing the guidelines, nor to the messy work of standardization, which we see more evidently in the literature, such as Stefan Timmermann's work, for example. So a difference then was evident between participants in where they locate problems with the intervention guide and the guidelines. So some would see the problems lay in its design, and others located it more within the implementation of the guidelines. And it seems that the problematization of implementation over or instead of seeing design as being problematic is an enabling factor in achieving the universality of MHGAP. So to kind of conclude, I'm going to talk through then some of the strategies that I've talked about, that we've seen with some of the quotes that I've used from the interviews that I conducted. And I'm interested then in thinking about how these are strategies that enable the construction of universality in global mental health. I'm not sure all of these are quite strategies or not. I would welcome your thoughts on this afterwards, and I'd like you to think with me on this, because I still think it needs a bit of work. But this definitely is some of the things that emerge from kind of thinking about and listening to what people said in the interviews. So firstly, it's the framing of universality as equivalent to action and cultural relativism as equivalent to nihilism or paralysis, as we saw, and that came across really strongly in the interviews. Another is acknowledgement of but delaying of complexity, or kind of bracketing out of complexity in favour of pragmatism. Okay, so we just need to do something now. We know it's more complex than that, but we'll think about that later, that kind of way of thinking. Another has been the prioritisation of systematic reviews and randomised evidence and research design in decisions about what counts as evidence. So it's significant to mention that in the making of the guidelines, qualitative evidence, qualitative research wasn't used to form the recommendations in the guidelines. Some qualitative research was used in a kind of additional way, but it was never the central thing that you could make a recommendation or not in the guideline. It was always results from systematic reviews or kind of randomised design. So another, I think we can see, is a narration of tensions through technical issues rather than around the epistemic infrastructures and epistemology of mental health's universality. It's a very wordy way of saying where the problems are seen to be is in the way that it's done, the way that it's implemented, not in the assumptions that are written into the design of the guidelines. Okay. And linked to that, possibly similar, is this ascribing of messiness to local contexts in which MHGAP is done, and not to the messy processes of designing and constructing guidelines or the messy work of standardization. So messiness is something that is about the way that MHGAP is implemented, rather than anything to do with the way that it's designed, I suppose. And let me just sort of end before I've put this last slide up. I haven't quite finished, sorry. So just to sort of talk you through some of the processes and thinking about those themes or those strategies, whatever they are. At first, in fact, I'll just put it back so you can see them. At first, I called this process of constructing universality, I thought about it as negotiated universality. And then I thought, well, negotiated isn't quite right here because not everyone gets a place at the negotiation table in terms of making MHGAP in this way. And folks with lived experience or who identify as service users or psychiatric survivors, people with psychosocial disability, are very much missing from the discussions around the initial making of MHGAP, certainly. And nor is the universality here always contested. So to call it contested universality is only partly true. At least it might not openly always be contested. It's definitely contingent, as Dorte Bems suggests, and it's also temporary, it's partial, and perhaps situated universality works better in that sense because it certainly is situated, as we've seen in the decisions made by a group of people who, while they may have experienced diversity in that group, were nearly all had training in psychiatry. And so this construction of universality, I thought, seems really interlinked with what the brilliant scholar Gigi Varonka, so she's a Canadian scholar with lived experience of the mental health system, what she writes about in relation to strategic essentialism. And she talks about it in a very different context. She's talking about the way the universalization of identity categories like you as a survivor or particularly lived experience, how that risks conflating and treating as homogenous quite distinct, to quote her, ideological and conceptual explanatory models. So it kind of collapses things together. And Varonka talks about the risks of strategic essentialism, so how it risks overlooking quite important differences. And she's talking about, as I said, within groups of people who identify under the umbrella of lived experience. But I wondered actually how strategic essentialism is also at work in this very different context of the making of the guidelines and of MHGAP. And that the guideline development group members hold quite different views about universality in relation to mental health, but they kind of put this on hold in order to make the guidelines, sort of flattening out the differing perspectives of the guideline development group as a political move that enables them to get something done. It actually enables the guidelines to be made. And I don't want to end the talk today without highlighting the importance of post-colonial, decolonial and Black feminist scholarship, which shows us much more generally the violence of the universal. And though that hasn't been something I've focused on here, I think it's really important just to raise that. I'm thinking particularly about Sylvia Winter, for example, how she teaches us that the conceptions of the human as a universal man is always an overrepresentation. So man represents itself as if it were the human itself. And Winter refers to that as being the coloniality of being, power, truth, and freedom. And I think that coloniality has really important lessons for us in thinking about the construction of global tools within mental health. One of the key tenets then of colonial violence has been the categorization of colonized lands as empty or as unproductive prior to colonialism. And in India, Bhargavi Dava, who's the founder of Bapu Trust, who I mentioned, the organization I mentioned earlier, Bhargavi Dava writes about the way current global mental health policies and practices and discourse can reproduce colonial practices of pushing indigenous medicine, healing systems that are indigenous or just different or alternative to psychiatry, and also just ways of conceiving of well-being and doing support that are not centered on mental health in quite that way that we might understand it in some higher income countries. She says these are pushed to the margins, they're made to vanish. And we saw in this work how, in the research I've talked about today, how some participants assumed that they talked about a time before MHGAP as if it was nothing, as if there was nothing being done before, and MHGAP enters an empty space. And in fact, the whole construction of a treatment gap and much cited statistics around how many psychiatrists per 100,000 of the population that we saw at the beginning of this talk that are used to justify task sharing, for example, as a dominant approach in global mental health, they have psychiatry as their main entry point. So if you look through that psychiatric lens and you're looking at how many psychiatrists per 100,000 of the population, that's a particular entry point that sees a kind of empty space then in that way. And I wonder what it would mean to have a very different entry point, to look at what's already going on in places without assuming that nothing is going on in that sense. And so why does highlighting then the negotiated and contested nature of universality in mental health matter? What's the point? I suppose I feel it's important for critics or people who want to think differently or critically about global mental health, because it helps people like me who are a bit critical of global mental health to see that actually many advocates of global mental health share some of the same concerns that we do, that I do. And some of those concerns are around medicalisation and pharmaceuticalisation. And actually, the interviews for me in carrying them out were really helpful in understanding how the construction of universal guidelines, even when they include, which the MHGAP guidelines do, psychosocial and social interventions, and despite the intentions of the guideline development group members, how those guidelines can still enable this kind of pharmaceutical creep, I suppose, to come in. And I suppose I was concerned about that. I had a feeling that might be at work, but it was only in speaking to the people that actually created the guidelines and have that deeper kind of internal understanding that I was able to see with a bit more nuance how that pharmaceutical creep might happen. And this understanding was really important for me. I was involved last year in drafting the UN Special Rapporteur report on the human rights-based global agenda for mental health and human rights, which I would really recommend. It's freely downloadable from the UN website if anyone who hasn't seen it. And I think it provides at least the report, and also the work that I've talked about today, I hope provides some ways of speaking across and between kind of these assumed but not necessarily essentialized positions of advocates and critics of global mental health. It troubles even those categories, and adds or shows nuance and complexity and multidimensionality where binary thinking, I suppose, has often dominated, or where we've seen there can be quite hostile kind of intellectual and practice-based debates. And so my hope then is that this work makes those links across and between arguments kind of positioned for and against global mental health. And I'll stop there. Just to say, if you can't get access to my book but you'd like to read it, I'm very happy to send you a PDF of it, so just let me know. And I'll end on this slide because Monica asked me to.
Thank you, China. This was a very thought-provoking, very interesting conversation. I'm sure, I mean, you've cited a number of people who are listening to you right now, so I can only imagine some of them will want to jump in. I'll ask a quick question, but then I'm certainly going to open the floor for questions and comments. I'm just thinking in the context of that hierarchy of knowledge and the cultural context that becomes the footnote. How did your interviewees see the role of cultural psychiatrists and cultural anthropologists? And I mean, how did they see you as well, and your role in providing cultural context and a better, more nuanced understanding of.
So that's a very good question. Thank you, Monica. They did not talk to me in the slightest bit about medical anthropology, psychiatric anthropology, so I can't tell you what they thought about that. Though, as I said, some of what they were talking about certainly shares some of the critique or kind of interest in some of the same processes, I suppose, as that work. What I can tell you about is that it was very interesting doing this research as somebody who was, I think, known to all of the participants, because they told me that. So everyone's positionality matters, right, when they're doing interviews. So if you had done these interviews, Monica, they would look very different than if I had done them, of course. But it was quite a unique-ish position for me to contact these folks to ask them to be interviewed, because I've probably written critically about quite a few of the people that I was interviewing. They all were very willing to be interviewed and gave quite lengthy amounts of time for some of them for those interviews, which I thought in itself is a really interesting engagement with critique. and a kind of openness, I suppose, to having conversations that they must have known what were going to be a little bit critical or perhaps potentially difficult. And so I thought that was really quite commendable and shows something quite interesting about some of the kind of advocates, so-called, of global mental health in that way. But yes, there are lots of times in the interviews where the interviewees would say things to me like, but what do you think, China? Because I know that you won't agree with this, or I know you're very critical of this. So my positionality in that sense as a critic, I suppose, was very prominent in those interviews. Even though I was there to listen to what they were saying, I didn't want to offer my opinion, but I was asked to in various points. And the conversations were quite interesting because of that. And I wondered if people perhaps were quite, well, either there isn't a real perspective that they hold, because of course they shift constantly, as everyone does in terms of those perspectives. But yeah, there was an openness to being critical, I felt, from the people that I interviewed generally. But as I said, I think it's helped by the fact that I've been doing this research for quite a long time within global mental health. I'd met nearly all of the people that I interviewed at various different points previously, not all of them, but most of them. And so, in fact, it was having a conversation with one of them, who I won't name, but who is a very prominent person within global mental health, that made me want to do the research in the first place, because of what they I suppose told me backstage, told me at a conference when we were just having a chat over a coffee, made me think, okay, it would be really interesting to somehow record some of this kind of critique from the people that are actually involved in these processes, rather than from people positioned to be outsiders like myself. But yeah, people's willingness to be interviewed was really refreshing and something I was very grateful for.
That's great. Thank you, China. All right, the floor is open.
Thank you so much. And I think even asking that question does something perhaps different than what we sometimes see going on within global mental health, because, and I'm talking about global mental health as if it's one thing, but as I've said, it's a whole load of different things, and I'm fully aware of that. Even asking the question of what's kind of already going on, I think is really important, and not to assume that nothing is. I think one of the things that really strikes me about a lot of work that happens in the UK as well as in India and all over the world in relation to mental health is that it often is not badged as being about mental health. So much kind of work that's important for people's well-being, if you like, it doesn't use the language of global mental health necessarily. And so I think having a way of accessing and learning about the languages that are being used by people to do that kind of work that might not use that sort of medicalized or more psychologized or medicalized, or however we want to see it, language of mental health is really important. So I'm thinking of just brilliant community kind of work that happens just around the corner from where I live in London, but also in some of the work that I saw happening in India. And it raises an interesting question, that to kind of access some of the funding, I suppose, that's been made available through global mental health, which it has been so successful in sort of making more funding available around mental health and making it more sort of globally salient to talk about mental health, I suppose, is that a lot of organisations have to orient the work they do to a language of mental health in order to be able to access that funding, when previously they might never have used that kind of language, and that might not be the language that they find the most useful. So having some kind of awareness of that as an entry point, I suppose, and not taking mental health as sort of the key words that you're entering in through, I think is a potentially helpful way to begin that kind of work. Well, I suppose thank you. I'm not sure I'm going to answer this very well, and I'm sure there are other people on this call, the Zoom, that could answer this better. I mean, I've worked quite a lot with Fanon's writings. Certainly, I found them to be incredibly useful to kind of thinking about how how to understand what we might call a sort of coloniality, I suppose, of global mental health. I know that's not the language everybody finds the most useful. And Fanon's work around it, certainly critical work around the sort of violence of universality, of universal man, I think is very useful in that sense. But I think this is also an issue of how do we see what comes to be called context at work within global mental health, as in we call it social determinants, or we call it social political determinants, etc., of mental health. And we could talk about the MHGAP guidelines as just sort of missing that kind of context, I suppose, though I don't think that's entirely, well, it's kind of partially true, I suppose. And I suppose with my work, I was interested to think about, okay, well, what's the context they're actually made in, rather than thinking about only the contexts that they're implemented in. Because often it seemed to me from the interviews that it was context that was problematized by the interviewees. So the way that the implementation happens into a context, the kind of binary of the local global, I suppose, how this universal guideline is done locally and that being located is the problem. And so whether or not we could incorporate things like the bigger socio-political, colonial, historical determinants that shape our sort of the psychopolitics, I suppose, if we're going to use Fanon, that shape mental health, I guess that would be, could we have guidelines that do that? I'm not so certain. And I guess that questions the very idea in some ways of universal guidelines, though we could argue that some of those psychopolitical processes certainly are universal. And as we become ever more kind of connected, and as climate change affects more and more of us, and then certainly there's perhaps a different way of thinking about universality in relation to that sort of that psychopolitical way of understanding mental health. I think, thank you for that question. And I think it's absolutely correct. I mean, I've got nothing to add to it in the sense of that's absolutely right, that those people most affected, you know, when I kind of talk about framing a social life of global mental health tools, a key part of that social life are the people that end up either using willingly or using through coercive measures, or, you know, being the users of some of those technologies, I suppose. And I think the perspectives of those folks are often either directly kind of omitted or are missing in certain ways, but not entirely. So I think it's worth, okay, I've got a few thoughts about this actually. So firstly, it's worth highlighting, and perhaps many of you already know about this, but maybe it's good just to talk about it, that there are groups of folks across global south countries, as well as within different countries, who have lived experience of, say, the psychiatric system or of mental health diagnoses, who are doing some brilliant work that we could also call global mental health. It just doesn't necessarily get badged in that sort of way. So I'm thinking about transforming communities for inclusion, which again, Bhargavi Davar is involved with from Bapu Trust, but I think it's something like 21 different countries across the Asia Pacific, if not more countries. There are, and they had a wonderful, relatively recent Bali declaration that might be worth having a look at online if anyone hasn't seen it, kind of trying to talk about the experience of people with lived experience of mental health systems, but how different that can look in what might be called global south countries, which is a problematic term. I know, I apologise for using it. And they point out, which I think is really important, how difficult it is to mobilise in some ways as people with lived experience, because different countries have such different histories and different systems and such different mental health sort of landscapes, that the terminology used varies so much. So what I mean is, some countries have got very entrenched colonial systems of psychiatry. They've got old kind of style asylums. Some countries haven't got any sort of solidified kind of mental health infrastructure. So in a lot of countries, to talk about service users or to talk about survivors of psychiatry immediately excludes a load of people who may have experience of distress, and they may have experience of trying to reach out to others and get support for that distress and not getting that support. But they're not necessarily psych survivors or service users, because the services just aren't there, or certainly aren't accessible enough for people to use. So I found the work of transforming communities for inclusion really helpful in that way, because they help us to see those very different kinds of histories and landscapes, and how actually the UN Convention on the Rights of Disabled Persons, so the UN CRPD, and the category of people with psychosocial disabilities has actually been quite useful in kind of bringing together, I suppose, quite diverse groups of folks for political action in quite a lot of countries across the global south. So that work is definitely out there, but I think often is very much missing from some of the sort of global mental health kind of discourse, I suppose, that I've talked about today. And in the citational practices of global mental health, it's also missing. So I often have this kind of strange, I'll read something that's written by someone who is an advocate, I guess, of global mental health, and they might briefly mention that there are some criticisms of global mental health. And I nearly always see Derek Summerfield cited as one of those critics, and there's nothing wrong with that. I like Derek very much and his critiques of global mental health. So I see him cited, and I sometimes see my work, and I think, okay, both of us are based in London. And actually, the critique, there are multiple other critiques of global mental health, including that have been written about, that come from folks in the global south, but they're not being cited and referenced in that way. So those citational politics are also really important. And I think absolutely that critics risk doing some of replicating some of those processes as do so-called advocates. I think we see that sometimes across both of those, not camps, but two different areas of folks. But thank you, that's such an important question.
We're having many hands raised and questions coming through the chat. That's very exciting. So Peter, do you want to go in, unmute yourself and ask the question?
Yeah, thank you very much. Sorry, the light is not good, it's late here. So now, Dr. Mills, thank you first very much. It was very, very interesting, and I found some of the concepts that you, at least to me, introduced, like contingent, universality, extremely helpful to get out of, let's say, dead-end debates that we sometimes get into, and also the way you say we shouldn't essentialize the positions in the debate into critics and advocates, which resonates very strongly because I'm a little bit of both to some extent. So, but that is sometimes difficult, and sometimes positions are so frozen that it helps actually think creatively and look at potential new grounds for commonality. So thank you very much. I do, in the meantime, have a question as well. No, one more comment actually. As you know, I'm, or maybe not know, but I've been quite close to the MHCAP development, and I think you did a very, very good job in capturing the hidden assumptions actually in the debates, because I was not one of your interviewees, but I saw some of the quotes, so that's me, or like I know. So I think you did it well, not the horrible quotes, by the way, but some, but I think, sorry. But so thank you very much. Now my question is about the pharmaceutical creep that you mentioned. And sometimes critics assume that it's big pharma behind it, which you didn't mention, and I don't think, if it is there, it's in a very insidious way. They are not on the at the table. They don't earn directly money from the work around MHGAP. But of course, there is this major issue of prioritizing pharmaceutical strategies in helping people with psychosocial disabilities or mental health problems. Now, and that has been, of course, recognized by WHO, for whom I do not work, and the answer was the scalable psychological interventions as a way to give more power to non-pharmacological interventions, because in practice, you didn't mention the practice on the ground, but I think anyone who has worked with MHGAP knows how easily it can go wrong, in the sense that the pill becomes the solution, which is almost a kind of almost a conspiracy between the client and the provider, because it's the simple answer that both want, and then you don't have to talk about difficult things. So the answer of the MHGAP community was to strengthen the psychosocial interventions by this range of psychological therapies, such as problem management plus interpersonal therapy, etc. How do you see this? Do you see this as actually something that could help, as a positive thing, or do you think it actually makes things worse? Because it is, of course, also built on theories of universality. And there is a bit more contextualization, but also not that much. Anyway, how do you see that?
Thank you so much. And just, I'm so glad that you found the presentation interesting and useful as someone who has been sort of involved in some of those processes. That's really interesting to hear. And just to say again, I mean, Dorothy Bem is the person who talks about contingent universality, and yeah, wonderful concept, and her work is great, I think, for showing some of those nuances that you're talking about that we need. I feel like in the interviews, no psychological interventions were met, or psychosocial interventions were mentioned in detail, so not by name of any of the sort of packages or modules, as they might be called in MHGAP. But there was, like I showed with some of the quotes from participants, quite strong emphasis on, but look, we do include these as well. And I think sometimes in the interviews that was perhaps done in a slightly defensive sense, though I didn't ask them about pharmaceutical creep, but sometimes as a defense that perhaps just came from a concern that I would think there was some sort of pharmaceuticalization or pharmaceutical creep, and others who were perhaps more themselves felt there had been that kind of creep. But as you said, people also did talk about the importance of there not being conflict of interest with big pharma, for example. And certainly in the funding and in the guideline development group members, etc., there was no representation in that way from big pharma, just to comply with the WHO's guideline development group guidance, I suppose, in putting the group together. That there couldn't have been. And one person actually said to me that I should have included the quote, but they said something like, in terms of, that the group decided they really didn't want that conflict of interest because they didn't want to be seen by critics as having their hands dirty. And I thought that was really interesting, because I think that it shows that there was a perception as the group formed and within the group about a concern about how they were going to be perceived by critics, I suppose, which I thought was very interesting. And in fact, linked to that, I spoke about in the kind of opening pages, if you like, of the guidelines, some funders are acknowledged for MHGAP. This is something I'm trying to look further into now. So if anyone knows any more about this and you want to have a private conversation, then email me. But some of those are governments that help to fund MHGAP. But interestingly, two of the funders, and it doesn't say how much money was involved in funding. One of them is Syngenta, which is a massive biotech, sort of biochemical company owned by Chem China. And one is Autism Speaks, which is an organisation, I think, in the US and possibly Canada, that I had come across before, because it's been severely critiqued by people who are autistic, as well as various others, for having, I suppose you might say, a quite eugenic approach to eradicating autism, which is obviously not an approach shared by a lot of folks within the autistic community. And so I asked about funding for the people that I interviewed, and there was a very just either no knowledge about it at all, or a couple of the people that must have had some knowledge of it. They didn't dismiss it, but they said it was about kind of personal relationships and people giving bits of money where they could. So it wasn't enormous amounts of money. And actually the whole thing was set up on quite a small amount of money when we think about kind of comparative global work. So the funding issue I thought was really interesting. And thank you for sort of raising the issue with Big Pharma. But in terms of the psychological interventions, yeah, I think there are also, there's a problem with critics, including me, thinking only about and focusing only on sort of psychiatry and pharmaceutical influences, though they are incredibly important, and I'm sure they are more insidious than perhaps I realise. Because we do miss, I think, in doing that, I miss that wider sort of psychologization that might be happening. And of course, there's a massive industry also in a lot of psychological interventions, and there's a lot of money to be made out of them, and a lot of the same problems that critics might level at psychiatry and pharma also apply to those psychological interventions. So I think it's important holding that critique in that kind of wider sense, I suppose, rather than focusing only on psychiatry and its links to pharma, because it kind of allows a psychological creep then, I suppose, that might also need problematizing. But just very interesting that some of the guideline developers, some of the people I interviewed, clearly do not see some of those psychological interventions as being universal. You know, there was a lot of discussion about them being cultural. So CBT, cognitive behavioural therapy, is cultural, whereas pharmacology isn't. And I thought there's just some very interesting different ideas about universality going on there that I suppose I was interested in the work. But thank you, Peter. Thank you so much, Ananda. Great questions. See, I knew somebody would want the mundane, banal stuff that I said I was going to miss out because I thought it might be boring, but you're right, it's so important. And thank you so much for joining from Sri Lanka. So the interviewees didn't speak so much about power or dynamics within the committee, though there must, of course, have been multiple different kinds of power dynamics, just looking at who was involved and their different sorts of positionality, I suppose, and positionings. And in terms of, yeah, how some people who sort of convened it, various people had different roles in terms of chairing it, bringing it together in terms of the guideline development group. How people were invited onto it seemed to me, from what people said, to be a relatively messy process of sort of people kind of, they already knew each other. So people were invited in that kind of sense. There wasn't some kind of application that was open for lots of people to be judged on if they, you know, what qualifications did they bring to doing it, and, you know, it wasn't an open tender or something. I think it was people were invited, you know, because those relationships already existed, I suppose. Going back to that quote from one of the interviews about it being a very collegial process, it was a group of people who kind of already knew each other and worked together largely, I think, who then formed that group, which is obviously interesting. And how, yeah, okay, so some of the strategies around managing tensions, just, I suppose, quite, there was a lot of dividing people up into smaller sort of work groups. They were often quite small groups of people, and some of the interviewees explained to me that's because it's just much easier to get something done, much easier to have a quicker discussion if you've got a small group of people. So instead of involving a kind of large group of people in each area of, say, putting together the evidence, there would be smaller groups so that it was easier to achieve consensus. So you're absolutely, I mean, that question, your question acknowledges the importance of how those sort of organizational dynamics, how the setup of something in that way shapes the product and shapes the experience, certainly, of consensus and negotiation. And also, perhaps just lastly, it's worth mentioning that there were a whole series of kind of scoping questions, I suppose, that were sought to be answered through the pulling together the evidence that we've seen was largely from high-income countries. And as far as most of the participants that I spoke to could remember, those scoping questions seemed already to be set. So who set those and how they were set is also a whole kind of other issue, and what, as was, of course, the sort of the act of sifting through evidence and deciding what kind of evidence would be used to make a strong recommendation within the guidelines in comparison to a sort of weaker recommendation, I suppose. And just worth mentioning that what some interviewees also talked about was the public health. There was a kind of idea of the public health costs and implications of different interventions going on in the background. So people were asked to explicitly think about that when they were part of the guideline development group. And interestingly, one of the things that they were asked to think about was the cost of not doing something. So what's the cost and potential risks of, I think one of the examples was having people who are non-specialists administer lithium in comparison to the costs of not doing that as an intervention. And so this idea of the cost of not doing something, especially when we think about what I've been talking about, I mean, pragmatism and kind of putting on hold or bracketing out complexity and critique, I think is probably quite important to the story of putting the guidelines together, actually. Thank you, Ananda.
Any more questions? There's, before I continue. Yes, Lawrence, go ahead.
So first of all, thank you very much for that, both for the sort of ethnographic work and for the larger sort of critical framework that you've been talking about. I just wanted, it's more of a comment than a question. I just wanted to say that the idea of universality is really doing a lot of important, not to say mischievous work in this whole process. And you've pointed to some of those, and I just wanted to rehearse a couple of them. We had a talk some time ago from Matthew Heaton, who talked about when the WHO began to get involved with this, with the move of Thomas Lambo from Nigeria to become head of mental health, he was very concerned, and this is, you know, contemporary of Fanon, very concerned to de-emphasize culture because of the concern it would be used in a racist way. So ironically, you know, this sort of insidious process of decontextualizing work begins with, we could say, a good intention of trying to avoid stereotyping people as it already happened and in a way. But we ended up, well, that's one thing that Universality is doing from the very beginning, is sort of trying to create a kind of equality. And there's almost a human rights argument that's behind that, of treating people equitably. And this has come up today at this very moment. There are discussions around DSM-5 TR as to how much, in the Black Lives Matters moment, how much specificity should be in a nosology about differences in society, and is acknowledging those, reproducing injustices, or calling attention to them in a constructive way. So there's by no means clear-cut consensus on how to manage this within, you know, technical institutions and professions and so on. So that's one issue of the universality. The other thing you mentioned is that there's a very quick conflation, which Arthur Kleinman criticized many years ago, between universality and biology, on the assumption that if it's biological, if it's universal, it's biological, that somehow these stand for each other. And of course, you can turn that around and say, well, they're existential predicaments that are universal for human beings. And, you know, therefore, there ought to be existentially oriented interventions that could be translatable in some way. But anyway, that is one of the things that unfortunately serves the sort of pharmaceuticalization. Two more quick things. So another thing about the universalization is it serves for fundraising. So some years ago, when they were trying to push broadening the movement for global mental health to address common mental disorders. That is not just severe, psychoses and things like this, which had been the initial target. And they were presenting to the World Bank. The whole point is to say, we know what the problem is for everybody, and we know what the solution is for everybody, so give us money. So this is not a pharmaceutical company now. This is people trying to mobilize resources, again, out of concern, legitimate concern about, equity and meeting needs. But part of their rhetorical strategy is to minimize the complexity and minimize the uncertainty and so on, because that's the only way they can, try to claim big resources. So that's another piece of the work. And the final two quick things. One, you highlighted the deterritorialization. So instead of understanding that these problems are always situated somewhere and there's an important story to be told about that, and that has to be part of formulating and intervening, there's also, and this is what came to mind when someone raised Fanon, and particularly Fanon from the point of view of the interiorization of colonial subjectivity, subjugation, is that MH-GAP is totally annihilates the interiority of people. It's not, there's hardly any place in it for dealing with the complexities of what an individual person might be experiencing, as distinct from the symptoms or the behaviors they're exhibiting. It's very much in that tradition, and that would be the target. So it's hard then to think about, not only do things need to be localized, geographically, but maybe they need to be localized within someone's story in some very intimate way that is, and again, I think it's obvious that would take a lot of time and the resources aren't there and so on and so forth. But I just want to say that the word universality, or the concept of universality, does a lot of mischief in terms of, stripping away all the things that might be central to some kind of person-centered mental health. That was clearly not a question, but.
Difficult to summarize in one slide, Lawrence.
No, thank you. That was really helpful though. And just to say, actually, I don't think I spoke about it today, but the people I interviewed were really explicit about while I said they could be critical about the guidelines and say, complexity can't be captured in a 100-page guideline, they also were quite explicit that the guidelines have been really useful as a cultural and a political tool. And a number of different people spoke about perhaps that's where the success of them lies, even more than in some of the other things you might expect them to do. So that was a key part of it, Lawrence. So yeah, thank you for highlighting that as well.
The time is coming up. I'd like to give the floor if Dorte wants to speak up, since she has been put on the spot indirectly several times during the session.
Oh, sorry.
Dorte, do you want to say a few words?
Thank you so much, China. This was very, very interesting, and I appreciate and enjoy any effort at sort of trying to map the messy middle ground in which things tend to happen, rather than sort of in the polarity of different corners, which I tried to describe in earlier papers. There's so much in your talk that is generative for me, because I also have done field work with global mental health actors, and had a lot of conversations at very different sort of scales and levels of intervention and policy making. So it's hard for me to pick one thing to comment on, but first I wanted to actually tag onto Lauren's comment to say that I think the universality in global mental health is actually not tethered to biology at all. It actually follows quite different mechanisms around what I have described a lot around simplification, that actually the idea is to create a common ground, that everyone, an umbrella language that is so vague almost and unspecific that everyone can subscribe to it and be enlisted in a project under very broad terms, rather than, or even MH-GAP is a sign of that. The priority conditions are how many, 8, is a massive simplification of the DSM or ICD, or the complexity we actually criticize in terms of the sort of Bible and manuals of Western psychiatry. MH-GAP is a massive simplification project and step to create something that actually obscures a whole lot of differentiation. And that's something I found actually much more important in the project of universality in global mental health to create these objects that travel because they're unspecific in a way. And then the next question then is, what kind of adaptation processes are crafted in order to give this unspecificity, like to operationalize that in context, as you say. And I think it's very important to exactly highlight that context doesn't just happen in low research settings, but exactly at the production of these guidelines as well. One thing I was really curious about, if your informant said anything about the way in which MHGAP took into account sort of field knowledge of NGOs and feasibility questions. Did they consider the ways in which you can craft a problem and a solution based on the existing health infrastructures and what you intend to do about it? Because part of the simplification effort, I think, has to do with what's matched on the other side, and that's the idea of the treatment gap and the lack of resources. And I found that the diversity that is often considered is actually the one of resources and of scarcity, rather than framed in terms of diversity or cultural issues, which is the kind of diversity we tend to focus on and we want to see more of. But the one that's actually constantly considered is framed around, what can we actually do? How can we craft something scalable, transferable, small, not too expensive, need to be practicable by lay health workers, because that's all that can be done. So I wonder if your informants told you any considerations around this kind of like field tested knowledge, like what is it that we can actually implement or feasibly put on the ground?
Thank you, Dorothy. And just sorry, I feel I put you on the spot because I mentioned your work so much, but I just think it's brilliant. So very briefly, because I'm aware of time, implicitly, I would say that was acknowledged, but not so explicitly. And I think, so what I mean is, if I understand you right, some of the people I interviewed spoke about the importance in putting the guideline development group together of having people who have experience of working within low and middle income countries. They weren't necessarily people from those countries, but sometimes they were. And of having people who have that kind of implementation experience, I suppose, within those countries. And so I think implicitly what you're talking about was being, it was felt that kind of experience was important to be part of the guidelines, because in comparison, for example, to lived experience, which wasn't part of the guidelines. So I guess there's a very interesting, there's something very different going on there in terms of that sort of practicality or forms of experience. But why it was important for people who have implementation experience from low and middle income countries to be part of the guidelines wasn't discussed in very much detail. And I sometimes wondered if there was a few people talked about the sort of representativeness, which I'm not sure is entirely the case of the guideline development group. And so I think part of that might be around, a sort of perceived critique, I guess, of that not. I feel like the critics of global mental health, in fact, are often, and sometimes rightly, criticised for being kind of armchair academics in global north countries. And I feel like the guideline development group actively did not want to reproduce that kind of dynamic, and they wanted people with that experience of implementation. But the reasons for that, or the kinds of knowledge that brings, or what that makes us think about in terms of evidence or experience, and why that's important, wasn't really talked about or elaborated on.
So thank you, China, very much for a wonderful presentation. Thank you, everybody, for staying with us and asking excellent questions. Thank you so much.
Thank you so much to all of you.
Bye-bye.
Bye.